continuing with our.
Wait.
Oh, sorry.
Now.
Yeah. Hi, everyone. So, in continuation with our classes on laparoscopic hysterectomy, so one of the features or one of the topics that everybody was requesting was on ureteric dissection and also how to protect the ureter even in simple cases. So, this becomes more and more relevant in the current times, especially when people start. I think elevating their skills from simple hysterectomies to a little more complicated ones, especially in cases where there are additions, where there is endometriosis, PID, and knowing retroperitoneal anatomy and also ureteric anatomy and dissection becomes very important. So we have, I think, operated quite a few of ureteric injuries post hysterectomies, both laparoscopic hysterectomies and also post open hysterectomies also, and some of them even vaginal hysterectomies, which Dr. Jay and in our facility, which we have corrected. So knowing ureteric anatomy and also knowing how to actually dissect it becomes very, very important, even in simple cases, because majority of the times we see ureteric injuries mostly in simple cases when we tend to get overconfident and start doing things without actually sticking on to the standard steps of hysterectomy. So first we will, I think, take inputs from Dr. J as to what are his viewpoints on this, and then probably we'll have a few discussion points, which I think many common gynecologists will definitely like to know. Yeah, over to you.
Okay. So I'll just quickly share the screen. I hope you can see the screen, right?
Yeah.
Okay. Fine. See, basically, one has to understand very simply, one has to understand this anatomy that if I'm drawing the uterus like this, okay, this is the cervix, this is the vagina, okay. Basically, the ureter is going to be somewhere here on both the sides, okay.
Mm.
And you need to understand that no matter how much you try, uterine artery is going to be here only.
Mm.
The step where people commonly injure the ureter is basically the step where it actually you want to go and coagulate the uterine artery. So your thermal damage will spread to the ureter here. Understanding? So what is it that you need to understand here? The first thing you need to understand is to do this. That is to give uterus cranial traction. And when you give cranial traction to the uterus, what happens? I'll just show you. See, it is beautiful what happens actually. Let's assume I have given cranial traction. One side I have not given cranial traction. One side I have given cranial traction. Okay. So we will be able to understand both the sides. The side where I have not given cranial traction, ureter is here only. Does nothing happens to that ureter. But the side where I have given cranial traction, see what happens. The vagina becomes flat. This particular hollow of the vagina goes away. Correct? The uterine artery becomes like a dundee like this because it has been placed in stretch, and the ureter goes here, which is why you are told that whenever you use any type of application, it has to be at the lower segment and perpendicular. Okay, now on top of it, if in case you are to separate the posterior leaf of the broad ligament, okay, then that separation pushes this ureter from this aspect to here. So this is the safety net you establish by giving two things. One is traction, and second is by cutting the posterior leaf of broad ligament. Now, if in case you are able to achieve both these steps, no matter whichever port you use, that means you can use contralateral ports, okay, you can use ipsilateral ports, you can use middle ports, you can use whichever things you want to use. And if in case you are able to achieve that, see, by doing something like this, I'll just show you. Just 1 minute. See this. I will quickly fast forward this to the point of interest. Look at this. When you look at this particular dissection, I'm sure you are able to see the screen. You are able to see the screen, Shilpa madam?
Yeah.
Like, see, when you are able to see the screen here, see this anatomy. This is where that ureter is. Can you start seeing the ureter?
Yes.
Yeah. When
Yeah.
you start seeing the ureter here, when you start seeing the ureter, let me fast forward it a little. Array, ureter finished in that one. Sorry. Yeah. See, just open the posterior leaf of the broad ligament. By doing this, automatically you have separated the ureter. Can you see? Ureteric tunnel has already opened. And because the ureteric tunnel has already opened, the ureter has simply gone and gone away from all the other parts. How does it help you in a hysterectomy? I'll just show that to you as well so that you know what. When you are trying to do a hysterectomy, it never ever ever you never ever feel that array acha I should have done something like this, you know. So we have a simple TLH also for an endometriosis, which I will play where this anatomy has been marked so beautifully. Just see. Just a minute. I will just fast forward straight to that point. Sorry, this is very dangerous case actually. Right. See this. If in case you are able to see anything through this, or if in case this seems to be very bad for everybody, I can play an easy case. You can see that is where you are cutting the uterine artery. Can you see? The uterine artery, there is some smoke there. The uterine artery is being coagulated and cut right at the perpendicular junction. So only when you cut it perpendicular, can you see that? That is the uterine artery cut. That is the uterine artery which is cut, and the ureter is so far away. Now, this safety net, if you are able to establish for each and every patient where you are attempting to do a hysterectomy, then what happens is no matter how hard you try, you will not be able to injure the ureter. The problem is, majority of the times as gynecologists, we do two things. Out of doing two, we do only one. That nahi, I will do any one only out of these two. I will not do two out of two. Okay. And when you are not able to do two out of two, one point will come where ureter is stuck to the posterior leaf and you have gone and coagulated that. One point will come where you have not given traction to the uterus in the cranial direction. See, somebody was asking me, do you use a manipulator? And I always tell them that I never use manipulation. There is no uterine manipulation which is done through an intrauterine manipulator or through a myoma screw in my surgeries. I will just give proper traction. And even that is enough manipulation. And if you are able to do that, 100% you will be able to achieve a surgery for hysterectomy without causing ureteric injury. Okay. If in case you start applying this even for very, very complicated cases, okay, extremely complicated cases, even then you will be able to achieve the exact same thing even in complicated cases. The anatomy does not change for complicated cases, only the adhesions are present in complicated cases. The ureter does not change its position. The way in which the ureter will pass through that region does not change its position. Nothing is going to change. Just remember that. You have to be focused in doing the same repetitive steps again and again and again and again and again. If you are able to do the repetitive steps, you will see in front of your eyes the ureter dropping down into the lateral pelvic wall, uterus going up, and when you coagulate the uterine, the distance between the uterus, I mean, the distance between the uterine artery and the ureter, at least being 3 to 4 centimeters. So even if you coagulate with a traditional bipolar, which nobody uses in today's time and age, even then you will not end up making a mistake in doing your surgery. Okay. So with that, I finished 10 minutes and I'll be happy to answer questions.
Yeah. So let's talk about like the sentence is wrong. Okay. Everybody uses bipolar. It is still a very widely used instrument to coagulate uterines because shearer sometimes, I mean, it doesn't really work in everybody's hands the way it works in your hands. So I don't think that statement holds good because many of us use bipolar for the uterines. Okay. So let's start a few things. So ureteric, the dissection, you think you should start from the sacral promontory wherever it
No,
then
not in
where
a case of a hysterectomy.
okay, so you suggest like everybody should learn doing ureteric dissection even in simple cases so that they are aware of the anatomy, they
The
are aware
simple
of.
cases are the best cases to learn it.
Okay. So sometimes what happens when we go near that ureteric tunnel, no? So we usually trace it halfway through and then leave it. And then think we just visualize it over the peritoneum. We don't cut the peritoneum till the uterosacrals and then we assume that it's okay. I mean, it's fine. We just open the posterior leaf of the broad ligament and then think it is okay to coagulate. So in such cases, like, I mean, how do you think everybody should approach? Should they know?
Two steps. Dissect the posterior leaf of broad ligament, coagulate the uterine at its perpendicular part to the uterine body. Both the steps are important. If you do any one, there is a chance of damage.
Yeah, I agree. So in your see, the uterine, maybe the coagulation, whichever happens. So what we usually do, I have seen you doing it in only one single area and then you cutting it. But what we usually do, how we do it in open hysterectomy, we put like how we put two clamps and then one artery to prevent the backflow, something like that. We do. We just coagulate it at two places and then cut it in between. So in these situations where we are using more and more of this coagulation and the lateral spread will be more. So I think like, I think over coagulating the uterine also sometimes can cause to this problem of ureteric damage thermally.
Overcoagulating without dissecting the posterior leaf will cause. Overcoagulating after dissecting the posterior leaf of broad ligament will not cause any problem. Coagulate the whole length. Coagulate it right till the cornu.
Yeah. So when we are opening the posterior leaf of broad ligament, sometimes that uterine vein, no, it will open and it will start bleeding. And it will be like, very messy, very difficult to control that. And it is like terrible. So that is when I think we get to think that, like, I mean, how to open, whether to open it here, there. So what is your tip on that?
Uh, no, I probably don't agree to that statement at all. Basically, that where in that situation, I'll just show you something, and that will probably answer that entire question which you just asked. Just wait. I'll just show you something. Yeah, of course, it is okay to open monopolar with hook. What is the problem? Open with whatever you want to open.
Array. That means like, with monopolar, is there more chance of lateral spread? Will the ureter get damaged? Or like, you posted one video today where you did that ureteric dissection with the scissor. I have never seen you. First time only today I saw you cut that plaque of tissue with the scissor. First time, in fact, I saw you using a scissor to cut it. So I mean, what is your thought? Like, because when we start the ureteric dissection, sometimes there will be those superficial bleeders which will start bleeding, and then you get very nervous that in the retroperitoneum there is bleeding, and then you abandon, like, even touching the ureter for the next two cases.
Yeah, just wait. Just see this. Hopefully, this will solve the problem. Okay, hopefully.
Maya?
No, sorry, not this one. I'm so sorry. I by mistake played the wrong case.
You only don't remember what you are doing.
Ah, no, no, sorry, sorry. I only played the wrong case only completely. See, I think maybe I had actually done something very nice. I just wanted to show that I'm just trying to find out where it went. Ah, here it is. Sorry. This is the one which I wanted to show. Now see this. This is what I'm trying to talk, madam. Can you see? This is your standard setup for a hysterectomy. Correct?
Okay.
Now, when you have a standard setup, na, see, You have cut. You have cut the ovary.
Yeah.
Saw that. So now when you cut the ovary, what has opened in front of you? It is the posterior leaf of the broad ligament. Correct.
Yeah.
I
Correct.
wanted to answer this question which you asked because you said that that uterine vein will start bleeding. Why
Mm.
will it bleed, madam? It will not
Array, it
bleed
will
only.
bleed. 100% it will bleed.
I'll
It
show
just
you. Wait,
happened even
madam.
in my Monday case also.
That is because instead of broad ligament, you cut the uterine vein. I'll show you why. See, when you cut the round ligament, no, madam, two leaves of broad ligament will open. Anterior leaf
Yes.
and posterior leaf. Correct. Now people will cut it there. They will kiss the
Yes.
uterus and cut the round ligament. Always go away. Okay, and open the round ligament little far away. Can you see that? Now,
Yeah.
when you open that far away, see that. Now
Mm.
this is broad ligament. Khatam. See
Mm.
broad ligament. Broad
Mm.
ligament. Now
Mm.
see one leaf. Can you see?
Mm.
Anterior. One leaf. Look posterior.
Mm.
If it is just the posterior leaf, you cannot go and damage that is the uterine vein. Can you see what I'm just separating that fascia? That is
Mm.
uterine vein. So what happens is see how posterior leaf went behind. See,
Mm.
saw that now gone. Now what you would have done, madam? You would have gone very medial here. If you go medial in this leaf, then you will cut the uterine and then you will start that array. It is messy, it is bleeding, it is this, it is that. But
Mm.
broad ligament has to be cut in the center. You can't go and cut the broad ligament the place where you want to cut the broad ligament. No. So if in case
Mm.
you cut it in the center, uterine vein will never come, madam. Just see this. Anterior leaf
Mm.
straight into the bladder. Bladder means UV. Okay.
Mm. Mm.
Everything will go. Now see, still this is broad ligament. See. Posterior.
Mm.
Nothing has happened.
Mm.
Correct. Nothing
Mm.
has happened. I have came close to it. Yeah. Close up picture. See. Now see, open. Just dissect. See this. This step is important. See this. Dissect. Don't just cut there. Dissect. Automatically your dissection will make sure that
Mm.
see broad ligament, uterine vein comes to the uterus and broad ligament goes to broad ligament. This step will make sure that this happens. Can you see? That is
Mm.
uterine vein. See down. See what I've just touched. I'm cutting one more. See, I'm cutting. Gone. Entire broad ligament is gone. If you dissect the broad ligament like this, it is such a probably simple and it is such a straightforward step in that entire procedure for doing that hysterectomy.
That is
When
not
you
how
do
we
it this
do.
way,
You are keeping it in the center. You are keeping the uterus in the center. What we do is we take the uterus a little ahead, like antivert, and then visualize the posterior leaf and then cut it. So probably, as you said, the medial going medial is the problem. Staying in the center of the broad ligament may be useful in preventing the bleed and also preventing the
absolutely.
ureteric, yeah, uterine vein injury. So tell me about this, like, the superficial vessels on the ureter that are there. So when you are trying to dissect the ureter and when you are trying to, like, make sure that you are lateralizing it in few cases of endometriosis and all. So if it starts bleeding, the superficial vessels, so do you think like we should apply pressure? We should, like, okay, okay. Don't look scandalized. I mean, how do
Yes.
we tackle it? We just leave it and then it will stop on its own?
No, coagulate it.
Array, ureteric, the superficial vessels on the ureter. What are you
If
talking?
it is spurting, you have to go and coagulate it. No,
Hmm, 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 hmm. But how
what?
far to go? I
You
mean,
have to coagulate. You have to just touch it. The bipolar just has to touch. Automatically, it will get coagulated.
yeah, the shearer, I think the amount of time you spend there, the buzz has to be like, 1 second.
Madam.
Yeah. I totally agree on that. So the more it bleeds, the more the vision is spoiled, the more is the difficulty in dissecting the ureter. And also, I think after 2 or 3 cases, you will understand as to how gentle you need to be and what is the direction of the
Uh,
dissection that goes.
no. Remember one thing. That is going to depend upon the severity of the case which you are handling. Let's
Mm,
assume the case which you are handling is really bad.
mm,
Okay. Then
mm,
what's going to happen is the entire anatomy of the ureter is going to be altered any which
mm,
ways. So you
mm.
are any which ways not going to understand anything.
Okay.
Learn to dissect the ureter and learn to separate off all the fascia in simple cases. When
Mm.
you learn to do it in simple cases, doing it in difficult cases is going to become easy for you. There
Okay.
is nothing, there is no such concept that, if you coagulate the vessels, the ureter is going to get bare, or this is going to happen, or that is going to happen. Such type of things don't really happen unless you really devascularize the ureter. Okay. So we are
Okay.
not really talking about devascularization. If at all it is bleeding, just kindly go and coagulate it. Do not let it bleed. That is important.
Mm. Mm. Okay. Fine. Okay, sure. So I think the two key points here are the traction and also the dissection of the posterior leaf of the broad ligament, which can prevent ureteric injuries in majority of the cases. In other
In
cases
all
where
the cases,
no, we will require to do ureteric dissection in difficult hysterectomies.
ureteric dissection is only required when the ureter has been medialized.
Yeah, but how
If
will
the
you know
ureter
it?
has not been medialized, then
How will you
all
know
this is not
unless
required.
you dissect it? You will not know it unless you dissect it. See, you will only see like two huge cysts which are stuck to the posterior wall of the uterus. You will see intestine which is stuck to the posterior wall of the uterus. But how will you identify whether the ureter is medialized, lateralized, whatever it is, unless you open the retroperitoneum and start looking?
That is endometriosis, ma'am. There it is different. I'm talking of TLH.
Okay, okay, okay. Sorry. Yeah. Okay, yeah. So I think the key points, I think you have covered it beautifully and you have shown as to how laterally we need to go to ligate the round ligament and also how to open the leaves of the broad ligament, which is also very important. And vault, I think vault opening and also how to coagulate near the vault we have spoken in the previous class and how to protect the ureter while suturing the vault. So I request everybody if they have any queries to please ask on our WhatsApp groups and we will try and answer it. So difficult hysterectomies and hysterectomy in cases of endometriosis, we will have another session so that we can discuss
I
each
just wanted
point.
to answer one question which came in the chat box. There is no role of doing pre-surgical ureteric stenting.
Mm,
I think if in case you do a pre-surgical ureteric stenting, you will make your surgeries much more difficult than what you will make them easy. Okay, so do
mm.
not get into that practice.
Okay. Yeah. Thank you